okay? You're gonna have your, already have that, okay. You're gonna have a secondary tubing, and I'll open all that up and show you on that. Most facilities have your little IV start kit that you've got everything in there except for your angio caths. So these are your, and y'all have, I think y'all have 6 in your bag. 6 little angio caths to practice with. Now, each facility, they may be a little different. Some people have little buttons that once you stick, you hit the button and it automatically retracts the needle back. I think the ones in y'all's bag are not, they don't have the buttons. I think maybe the ones we have here have buttons. So you're gonna have your primary bag and tubing, secondary bag and tubing. You're also gonna have an extension set. Because when you start an IV, the easiest way, once you get that in and you take your retractor out, you have to put pressure on it or, you know, and it's messy, y'all. IVs are messy, some more than others. But it's very easy to have your extension set ready with your flush hooked to it. But you're gonna prime it with the flush first. Then you can just hook it up to there and check it, make sure it's in, okay? So, I'm gonna go ahead and just get everything set up. Of course, you can always, you know, go in and explain to your patient before you bring a bunch of supplies in what you're fixing to do. It's okay to ask them what, you know, if they have a preference on one arm. If they're right-handed, typically you don't want to try to put it over there. Of course, their better veins are usually on that side because their dominant hand, they use more, so you're going to have bigger veins.
Is there any reason that they may have that you can't use one or the other?
Officially,
Fistula,
oh, mistake.
dialysis,
Right.
Mastectomy? Okay. So they know that.
Yeah, and especially if it's the older mastectomies where they actually took lymph nodes out.
Mm.
That's what you cannot do. Now, if they've had the newer surgery, now they can just go in there and put dye to see which nodes are positive, which lymph nodes, so they don't have to take all the other ones out. So if you had somebody like that and your only vein was on that side, you could put it in there, but it's the people that had mastectomies where all the lymph nodes were removed.
What if they've had a double mastectomy?
They've had a double mastectomy that makes it a little, a little harder. In fact, you'll see some cancer patients that, you know, these portacasts that they put here, sometimes they put them in the groin area when they've had double mastectomies. That one, if one is older than the other, you would typically do that arm. If they've been recent, you might have to call the doctor and say, you know, ask them what they want to do. They might need to have maybe a port put in or something, especially if they're gonna have chemotherapy.
But it's a good question.
Yes. Okay. So you've gone in and explained everything to your patient. So I will usually go ahead and try to get so let's say the doctor's ordered for them to have a bag of 250 mLs of normal saline, and some of these are harder to actually. A lot of them will have little tabs here where you can tear down the side, or you can look for, and you'll see some nurses get their little scissors out.
A lot of them have little notches.
Uh-huh.
That you can tear them.
So, now, there's 2 different sides. This one is one that will not come off.
Mm-hmm.
That would be a port. Say you've got fluids hanging and the doctor decides, oh, their potassium's low. This is if you need to go inject potassium in there, if they decide they want something to hang. That's for injecting medicines. This side will usually have a piece that you pull off. And today when y'all get through, after y'all practice, y'all can put these back on. Don't throw these away because you might want to save your bags to practice. And that, as long as you put that back on, it'll be okay. So I'm gonna open up my primary tubing. And one thing you have to do with tubing is there's a spike end and there's an end that will hook into your extension set with a little lure lock area. You always wanna make sure before you spike that you clamp your tubing. If you don't and you spike and turn that fluid upside down, it's gonna go all the way out, okay? So you always clamp that. You don't have to do all the clamps. Some nurses do, but really, if you've got that one all the way down, that's all you need. So, you wanna take your end off. Do your fluid upside down. It's you're just gonna twist it until it gets almost to the end. It'll kind of get to a point where it won't do anymore. You're gonna hang your fluid. You're gonna fill the chamber, squeeze the chamber and fill it up about halfway. You don't want to fill it all the way up because then you're not gonna be able to see. Remember how we talked about drops per minute?
Mm-hmm.
So, I should have looked. Let's see what it said.
You notice that she put the reading part out to where everybody can read it, as opposed to hanging it like that, okay? That's particularly important when you've got antibiotics, medications.
So this says, 15 drops per. So every manufacturer can be different, every hospital, depending on what fluids they get. So, so I usually get that about halfway, so that way I can see the drops come in. Then you're gonna prime your tubing. You don't have to take the tip off because the fluid will come out, so that way, if you take the cap off and it drops or something, you gotta go get another. So you're gonna open this all the way up. Another reason why you wanna get, see how it's streaming down? Another reason you wanna get that halfway full is that you want to not have a lot of air in your tubing, and that kind of prevents it from doing that. Okay, it's all the way to the end. Okay. So then once I get my primary tubing, everything ready, I'm just gonna put it like that for a minute. Because I know once I start my IV, I've got my extension set. So I won't have to hook that up till after I flush and get it all secured. And then we'll do the secondary on our push. Okay. So usually in the hospital, you'll see nurses grab an IV start kit. They'll usually go ahead and grab a couple of angiocaths. Because sometimes you don't know what size you're going to be able to put in. And you don't want to have to keep going out of the room, you know, to go get something. So I'm going to go ahead and open up my IV start kit. And of course I would have my gloves, just regular gloves. This is not sterile procedure. So you put your regular gloves on. Probably the tourniquet and learning how to feel and do everything with gloves is the hardest part, okay? So that's gonna be my little Tegaderm, my little cleaners. You also always want to make sure that you get your tape ready, because if you start an IV and your tape's not ready, it's like, and I'll show you once I start, if you don't secure it with at least one piece of tape, it'll flop around. But what I typically do, and you can do this before you even, I'll usually open this up and grab the tourniquet out. I'll go ahead and look first. Because, you know, you get everything ready and you get, especially if they don't have very good veins and you know, you can only have this pulled for so long. The easiest way to do a tourniquet, because I'm right-handed, is I go ahead and put it up under there, tug, then you're gonna crisscross and swap hands. Okay? So where I started with my left hand with this right hand, crisscross, then I'm gonna put my left hand with this one, my right hand with this one. Then I'm gonna pull. See how I got this index finger right here? Holding that tight. If you don't hold that, it's gonna loosen up and you're not gonna get tight enough. So pull, and then tight. When you're first learning how, some people want to feel like they need to make a knot. You don't make a knot. Because if you do, when you go to pull, a knot won't pull out. Even when you're through. you still have to, I still after 40 years, when I'm getting ready to do an IV, I have to tell my mind, take off your tourniquet, because that you'll forget to take off the tourniquet. So, okay, I'm gonna say that I've looked and I have found a good vein. So now I'm gonna go ahead and get everything, and I'm saving all these little things. Okay. With your tape, you can clean off a place on the bedside table, put your tape, or you'll see some nurses put it on their glove. You just don't want to put it down tight on your glove. Have a little end up. You don't want to put them on your scrubs, because you don't know what's splattered on your scrubs. You don't want to put them on the IV pole, one of the dirtiest pieces of equipment. So I'm going to say that we've cleaned off right here. My first little piece, I'm going to tear in half. I'll show you why in a minute. But only one of those. And then I'm going to have one other piece ready. So once you get the IV in, again, you're just going to put one piece of tape down, because you got to make sure that IV is in there, it flushes well before you can put your Tegaderm on and get it all down. So, got my tape ready, I have my tourniquet here. Mr. Cresswell, I'm going to get you to hold that arm right there. Okay, so I'm going to have my tourniquet ready. Now, I want to make sure that I open up my extension set, and I'm going to go ahead and hook my flush to it, because you've got to make sure that, and again, it has an end. That's what you call a needleless port. So it looks like a lure lock, but it's got a little septum there. And then you're going to have one that will actually hook into.
It's got threads.
Uh-huh.
It's got threads.
Mm-hmm. Remember how we looked at last time the different syringes, slip tip, and the. So you see the extension set's short. So these are real good if you've got to draw labs on your patient when you start your IV. What you would do is get it inserted into the hub of that, and you would just hook up syringes and pull the blood out. So I'll show you how to do that. So I'm going to check. The way these do, you have to push this in and twist it. Okay? So we're going to check, and I don't have it clamped. I'm going to check my saline. Then I'm going to clamp it, because if you don't, the saline might come back this way. You want to make sure that saline stays at the end of that, because if you give it air right there when you hook it up, it's going to put air into the patient. Okay? So I've got my extension set.
That's just a little slide clamp. You just look at it and you see when,
Yeah,
when you
slide.
open it and when it tightens.
So I'm just going to kind of loosen this cap, just to make sure it's on there so I can get it off easy. The thing about the AngioCast also is you want to loosen the cap a little bit. So these have little buttons that you just hit the retractor butt.
What you need?
I was just seeing if y'all need flushes before I throw this one on.
Oh, yeah,
We
put
couldn't
right
find
there,
that
because I
many.
might, thank you.
Okay.
Okay, so
Got several gloves are right here. I was looking for flush. I was gonna see if anybody needed that
they're
flush
not this
before I
hard to
threw
come
it
off in
away.
the hospital. Y'all's are much easier to come off than that. Thank you.
Difference?
Uh-huh.
Gloves.
So,
I got a good grip.
Yeah.
She was sliding.
yes, and remind me to show y'all something too about the tourniquet if you have a hub that's stuck. So you want to take that off and just kind of leave it loose. So when you get ready to stick, after you've cleaned, you can just pick it up, do like that, and the cap comes off. Because if you clean and you haven't done that, what have you got to do? You clean, you have to go and do this.
Right.
You might hit their arm, and then you're going to clean off.
Right.
And you might forget where you cleaned, you know?
Can you do like the little pin, like the little mark? You know, it's sometimes a little mark when you find a vein.
You will see some people that will actually put a little mark. Something I do is after I clean it with my alcohol, I'm gonna pretend this is my alcohol swab, and you're cleaning again, just like inside out, because you wouldn't do inside in because you're pushing the debris back in there, is I leave my little
Okay.
bed over there
All right.
too.
All right.
So, okay. So I've already explained, of course I've already checked my order, you know, I've explained to the patient what's gonna go on, I got everything ready, so I'm gonna pull, hold those two, and tuck, okay? So, you'll kinda have to see with patients, if you're right-handed on their side, sometimes you have to pull their arm out to the side, wherever you're comfortable doing that. Okay, so, kinda now, I'm gonna just say I'm gonna go right here.
Yeah, I
And
see.
inside out, remember you don't do like that, you just let it dry for just a little bit.
So I'll give you later.
I'm gonna pick up my needle. I'm actually gonna do it first. I'm gonna do it
So
this
you
way.
clean after you do the tourniquet, right?
Uh-huh.
Okay.
Okay, hub, bevel up. If I can see it, y'all. I'll read her
Yeah,
back
your
here.
glass, I was gonna tell you, your glasses on top.
Okay, bevel up. So, you still, remember how you do an intradermal? When you pull the skin, this is kinda almost like an intradermal. So you kinda wanna pull, some people will do like this, but you might slip and hit your finger, but usually you just kinda pull the skin down. I'm gonna tell the patient it's gonna be a stick, so when you inject, we didn't retract the needle, okay, so when you inject, it is gonna be a pinch. And remember the angle, you're not going in like a 45-degree angle, it's almost parallel to the skin. What you're watching for when you get that in there is what?
Flush. I mean blood. You know.
Uh-huh. Now sometimes in these arms you don't see it as well. There it is, see? Just a little bit. Now regular patients you're gonna see. I mean it's gonna be, you know, deep red blood. Once you see that flash, you're gonna go. How many did she tell y'all so much further in the video?
Well, it wasn't as clear as it is right now.
Okay,
so.
I got you. So you want to go up a little bit further and see, you don't want any of this sticking out.
Okay.
Okay? So once you get in there, you're going to travel that vein. This one has a little button, I believe, that it will track. Wow. I might use one of y'all's needles because I like y'all's needles better. There's a little button that's supposed to retract that. Okay. Okay. Then you're going to take you're going to finish making sure none of that's in. I'm going to put a little pressure that because once this comes out, it's usually going to leak. Then it's not leaking. Then you're going to put, again, you got to put it in, twist it. Now you don't want to put it on there so tight that if you need to go take it off, and then you're going to pop your tourniquet. You don't want to put it on there so tight so if you have to take it off and change tubing, you can't get it off. A trick that you can use with tourniquets, you'll see nurses carry these a lot in their pocket, is like with his gloves, you can use this to help twist it open. Okay? So once you get your IV in, you want to use a piece of tape, and usually what I do is put it right over that little hub. If you don't put a piece of tape, what's going to happen? It's going to do like that. Now that's plastic, it'll bend, but you could possibly shear it off. Okay? Back when we learned how to do IVs, the first angiocasts we had to work with were all metal. So once you put it in, that's why we never tried to put it in here because they couldn't bend it. Because it was metal. It wouldn't bend, but these are flexible. But they can come out. So you want to put at least one piece of tape right there. So see, now it's not gonna.
Mhm.
So then I'm going to unclamp so I can flush. I'm gonna flush. Of course, that would be all the way in. Flush. I'm in my vein. I'm going to clamp that back so I don't get a backwash. Then what I can do, actually before I do that, yes, thank you.
Here, I can't see with your
So
hands there.
then again, remember y'all with scoop, because it's been in the patient, right? Although it's the little stylet on the inside, you still don't want a chance.
Mhm.
So you can do that. Then I'm gonna go ahead and put another piece of tape, this small tape. Now in the video, I don't know if she told y'all how to, did she show you how to put a piece up under here?
No, ma'am.
Okay, so you'll see nurses do a couple ways. And it's kind of to keep that hub from flopping. You put a piece of tape up under that. You can do it two ways. You can make an X, so you could put one piece that way, one piece that way. Or some nurses like to do a football goal. To do the football goal, you would go up under here. And of course, you would not have fingernails as long as mine. I always bite my nails, so I'm excited I have nails. The football goal, you put it directly under there and just come fold that sticky side up like that. Well, like that. And make like a little football goal. I think it's easier to crisscross.
Yeah, that's
I like
what
that.
I'm-
Crisscross.
Crisscross is much easier. So then you're ready to put your Tegaderm on, okay? So you want to try to get the site of the needle in the middle. So you use just, I do it better like this on smaller pieces. So, and you want to make sure it seals. Now you don't want to mash real hard because they just had that IV put in. But then you're going to take this off. You're going to save the part where you're going to put your initials and the date. Most facilities will change tubing every 72 hours. It may be different somewhere, so you'll just have to check your hospital policy and procedure to see how many years. The tape at the hospital would come off much better than that.
When I went to clinicals, the nurse at the UAB, she did everything before putting it on.
Oh, that's so then she had everything.
So then
And
she
that's,
just
and that's,
puts it-
yeah, that's fine to do. So put AC, today is 6/25, 20.
And you notice she kept the slide clamp out, not under the tape.
Uh-huh.
Okay, you
Yeah.
wanna still use that?
Yes. So you put this on. Now, what would you document in your electronic record about your IV? What information?
The size gauge.
Gauge,
And where it's located.
where it's located?
The date and the time that you started it.
Yes, and I usually will go ahead and say, flushed IV, with however much flush, no swelling or redness noted. That way, in a couple hours, if they've hit it or something, somebody can't say, well, you left it like that. Well, no, I didn't. I documented that Okay, so we flushed, so now, if they've got continuous fluids, I'm simply, and go ahead, like when we talked about injections, the vials, even though you take that little cap off and you know that rubber part's clean, go ahead and get in the habit of cleaning. Every time you come to a side port, needless port, you clean. Just get in the habit of cleaning with it. So I'm gonna take my extension, my flush off right there. I'm gonna leave my extension on, because it's got that little port there. I'm gonna clean it. Again, you have to give it a little push and see, you can see the Lure-Lock tracks. Again, just enough for it to be snug. You don't have to put it on there like Hercules.
Righty tighty,
Uh-huh.
lefty
That's
loosey.
Uh-huh,
Right
yep,
tight.
okay. So now, I've got my continuous fluid, then you could take your other piece of tape. And, you don't wanna get it so, you want to have a little loop. You don't wanna tape it usually here, tape it down here. So, You could even do it like over that. So you just wanna make sure it's not kinked off, okay? So that's one thing you wanna check for your patients that have IVs, cause sometimes if they get too tight, they'll clamp, kink off, and then there's nothing going through there. Okay, so let's say now they've got an antibiotic, that needs to be hung. We're gonna act like this is our, antibiotic bag, that it's already got antibiotic in it. So I need a secondary tubing, because the nice thing about pumps, when we didn't have pumps, and we had to hang something, we kinda had to think in our mind when it might go out, to go back in the room and change it over. The nice thing about pumps is that once your secondary has infused, your primary will pick back up. But at some point, you gotta go back in and change it again. I think this one has a little side thing, yeah. You're gonna do the exact same thing. I'm gonna clamp it.
And that's really important, cause if you don't clamp it there, it'll be through in 1 second.
Yes.
It'll be out.
Again, it's got the, same little 2 ports. I'm gonna take that one off. I'm gonna spike it.
Go straight in with that spike, because it will cut you like a knife. And you already cut the bag, and then you gotta throw the whole bag
Now,
away.
while I'm priming it, I'm just gonna put it back up here, and then we're gonna show you that. Putting the primer down. So we'll get my- Some of these chambers are harder to squeeze than others too, so, okay. So, now, your secondary tubings are sometimes, longer than this. This is a pretty short one. Also, there are different type tubings. You may open up a tubing that only has 1 port. You may open up tubing that has 3 or 4 needless ports. So of course, this is short, so we're gonna go in the closest that we can. So, again, you would clean this. Put this in here. Now, my primary bag, I'm gonna hang lower, because I want my antibiotic to go in. So I'm gonna put my primary bag down here. Okay? Secondary. With the pumps, because that's connected into that, there's a way for you to program your information about how fast that needs to go in. So once that goes in, and there's, it goes down to where the part of the pump where it can't sense any more fluid, this will start dripping again. So next time you go in there, you can just change it. They typically will use the same tubing, again, every 72 hours. It may be 48 hours, so you'd have to look and see what the facility said, how often. And they'll put stickers on the tubing when it was changed, so people can, it takes too long to go in your electronics and say, when did they change that? Change that tubing. Okay, so then, once that is done, you can hang this. Say, well, I'm gonna save my tubing that's empty. Typically you would have your other side, you could put that over there, you could leave it here. Some nurses will go and take that out, so say it's done, those little blue caps, you'll have a lot of little blue caps in your pockets. So once you take that out, you put your little blue cap back on. Okay? So now, say the doctor's come in and he's ordered for the patient to get 2 milligrams of morphine, IV push now. So, we're gonna say that there's 2 milligrams of morphine per 1 ml in our vial. So what's the first thing we're gonna do?
What's the order dose?
So it's 2 milligrams IV now, and my vial says 2 milligrams of morphine per 1 ml. And so I'm gonna need to give 1 ml. So what do I do first with my little vial?
Clean the top. Clean the top.
Clean the top.
Clean your hands
Gloves, yeah.
and gloves.
Air. I heard air. Yeah.
Yeah.
Of course, I would have my gloves on.
Right.
Yeah, air. A lot of people yesterday forgot about the air. Oh yeah, I forgot about air. There was some group too that went to, I think it was Prattville, And they said, the Prattville nurses said, if you put air in the morphine thing, it's gonna explode. I said, what? No. If it's an ampule, yes, but if it's, you know, of course, if they're those pre-filled, you would never, you know, put air, cause they're fixed doses, so. Okay, so I'm gonna pull it back to 1 ml. Clean, remember air to air. Air to air, pull back. Now, when you're giving something IV push, you're always gonna flush before the medicine and after. Because you wanna make sure if there's any blood, maybe right there, you just kinda wanna get that cleared. So I've got that. So then I'm ready to go in there, and again, I'm gonna do, this one you don't do it, okay. Okay, so typically with IV pushes, you wanna do the port closest to the site. Because if you do it way up here, and I've only got 1 ml, and I put the 1 ml here, I would have to flush with a lot to get it in there, okay?
Otherwise, it'll be trapped in the tube.
Uh-huh. So, you're gonna have to, clean, and what did they tell you how fast to do IV?
A minute per
Per minute.
milliliter.
Uh-huh, yes, 1 milliliter
Per minute.
per minute, So, I'm gonna take my port, I'm gonna pinch that off, I'm gonna clean again my port, and then I'm gonna probably pinch it right there. I'm gonna put this in. Yes, somebody yesterday went, "Whew," and I said, yeah, you probably just killed your patient. Or the respirations will probably, so yeah. So typically, if you don't pinch that off, if you go fast, it's gonna go whoop, walk back up there. So if you push slow, you can. You don't have to, pinch that as much, because if you've got the pump going and you pinch too hard, it's gonna beep. So your IV push. So then what are you gonna go document about your IV push medicine? In the MAR.
The rate it was administered, the dose that was administered.
Yeah, so the MAR, after you scan the patient's band, and then what are you gonna do with pain medicine? After you give it, what are you gonna do? How are you gonna check?
I know you get another nurse to check it with you, right?
What, you do that, you do, you do that. Here, you go back 30 minutes later and check their pain level.
Okay.
Uh-huh.
Oh.
Yeah, that's right, yeah. Okay. And what did I not do before the medicine?
Flush.
Flush, yes. So, policy again, some facilities do 5 mLs before, some do 10. So, it's
Can
just-
you use
just kind of according-
the same syringe before and after?
You can. So if you